by the Family Planning Association. So my one is just basic what you have to know about family planning, right? So okay, can you see my slides?
Yes, sir, we can see.
Okay, so what we are going to talk about is contraception that we can use for women, family planning and contraception. So there are so many types of family planning. When you ultimately your choice is to offer the most suitable one for the woman. So it's about individualized care. Now trend is about individualized care, personalized care. So we just can't say a blanket term and say, okay, everybody use OCP, everybody use Myrina, everybody can use this thing like that. No, but you have to give a tailor-made system of family planning. What suits each woman most, so that they will stick to that family planning. If it suits them, they would stick to it. If not, they might deviate from it and ultimately get an unwanted pregnancy. Right. So how to decide on the suitability is the WHO has released a book. It is called the WHO MEC, or WHO Medical Eligibility Criteria. Actually, this is not about the social and the physical aspect of it. It is more of the medical aspect of how to prescribe a contraception. So in the medical eligibility criteria, they would say which criterion will suit each woman. So some contraceptions are not suited for some women due to their medical conditions. So because of that, we have to know about this medical eligibility criteria to counsel women regarding which contraception that suits them most. In addition to these things, we have to take into account their social life and their personal life and all these things as well. For example, what sort of a job they do, what sort of sexual behavior they have. These things also has to be taken into account when you prescribe a proper contraception. So the medical eligibility criteria has four categories. So these categories are 1, 2, 3, and 4. So if a drug for a certain woman, if we analyze it and we say it is medical eligibility criteria 1, that means we can use it without any issue. If it is 2, it can be used, but there are some disadvantages, but the advantages outweigh the disadvantages. If it is 3, there are some disadvantages, which the disadvantages outweigh the advantages. So it is a little bit of a risky thing. For example, if there's a heart disease patient, then we are going to start oral contraceptive pills. It might cause thrombosis and aggravate the heart attack. So then it is medical eligibility criteria 3, category 3. Category 4 is, of course, very, very high risk and unacceptable risk, and you can't start. For example, someone like trying to start oral contraceptive pills for a woman with thrombophilia. A woman who has a family history of thrombophilia. It is really unacceptable for us to start oral contraceptive pills for these women, because there is a very high risk of thrombosis and they will die of a thrombotic event, maybe a pulmonary embolism. So that's unacceptable. So we have to see which category these women will fall into in each type of contraception, and we have to offer the best one. So best one would be medical eligibility criteria category number 1. Category number 2 also can be given if category number 1 is not there. I mean, if there's no category number 1 for that woman, or if that woman prefers the medication and it is in category number 2, still we can offer it to the woman. For example, it depends on their sexual activity, their social life, and all these things. Sometimes women does not like long-acting contraception like Jaded. A progesterone-only contraception can cause irregular vaginal bleeding, so they might not like it. So in that case, even if it is category number 2, we can offer them oral contraceptive pills, something like that. So first things first, the most common contraception that we all use the oldest type of medicine and the widest used medicine in the world is oral contraceptive pill. The pill is correctly termed combined oral contraceptive pill, COCP. So they have progesterones and estrogens, and there are preparations which are either the phasic preparations or they are monophasic preparations. Monophasic is they have the same dose, so they does not mimic the menstrual cycle. So the side effects are a little bit more in the monophasic preparations. But with time, they made triphasic, biphasic preparations where it mimics the hormonal environment of the woman during the menstrual cycle. So because of that, the acceptability is high. If you give the same dose of estrogen and progesterone throughout the menstrual cycle, then it is not the normal hormonal environment that you get in the woman, and that they might feel nauseated, vomiting, and abnormal bleeding or abnormal tummy pains and all these things during the cycle. But if you just mimic what is there inside, just the same thing, then of course you might get a better compliance of that woman to use that contraceptive, right? So the commonest estrogen that they use, combined estrogen and progesterone, is they have both in these pills. The commonest estrogen that they use is ethinyl estradiol, and the commonest progesterone can be of different types. So there are generations. So first generation, second generation, third generation, and fourth generation. So noethistyrone or levonorgestrel, desogestrel, destogen, drospirenone. So many types are there. The latest types are these contraceptions which use drospirenone. These are basically in the trade names of Yasmin and Delcia and all these things. This progesterone component has very weight reducing properties. It is a diuretic, so it will take out water from the body and even make the woman a little bit thinner. So that's why the newer generations ones are more famous than the older generation ones. So how do they act? They act by inhibiting ovulation, and also they will prevent the ovarian, the follicular maturation process. So there won't be a follicle maturing, and it will prevent ovulation, and it will also prevent sperm penetration by thickening the cervical mucus because of the progesterone component. And not only that, the implantation is also hindered by that progesterone environment, right? So because of that, because a lot of mechanisms come into play in oral contraceptive pills, they are very high efficacy medications, right? So normally we give oral contraceptive pills in 21 pill packs. So you take 21 days and you stay without the pill for 7 days. You start the pill pack on the first day of the menstruation, and after that you don't count the menstruation, you just count 21 days and then stay pill free for 7 days. The common contraception that we have in Sri Lanka, which is the Mithuri, have a dummy pill for the 7 days. So when you have a dummy pill, you don't have to worry about it. You just continuously take for 28 days. Give me 1 minute. Hello. All right. Okay. After channel. Okay. Right. If the pills are correctly taken and in a very consistent way, they are very high effectivity, right? About 99%, more than 99% success in preventing a pregnancy. So you can tell that if you take it properly, you are very good at preventing an unwanted pregnancy. But the problem is that when you're taking a contraception, especially which is dependent on the woman to take that on a time, then the using the efficacy might be different from its actual effective, because as humans we always forget, and that is called the typical failure rate. So there's a typical failure rate and the ideal failure rate. In ideal situation, it might be very effective. But in a typical usage, it might be more less effective because actually we forget to take the pill. Then of course, we can't say that the pill failed, actually we failed. That's right. Okay. When we are talking about the contraceptive benefits of a contraception, we talk in the word called the Pearl's index. Now, the Pearl's index is defined like this. It's if a woman uses a contraception, if one woman uses a contraception for 100 years, this is imaginary definition, or if 100 women use a contraception for 1 year, how many women will fail? If you get it again, I will tell it again. Pearl's index is if a woman if a woman uses a contraception for 100 years, what is the chance for her to fail? Or if 100 women use it for 1 year, what is the chance of that contraception to fail? So, if you take oral contraceptive pills, it is 0.3 to 4.4. That means 100 women years gattama, 100 women using for 1 year or 1 woman using for 100 years, the failure rate is basically 0.3% to 4.4%. So it's very highly effective if you can just grab what I told, right? And it has a very high non-contraceptive benefits, right? It reduces the risk of cancer like ovarian, endometrial, and colorectal cancer. It improves acne vulgaris, right? It improves the bone density. It actually regularizes the menstrual cycle. And it actually can reduce the weight in some oral contraceptive pills. So it improves the skin contour. So a lot of good benefits are there with oral contraceptive pills, right? It can suppress endometriosis, adenomyosis, all these illnesses we give, right? It reduces pelvic inflammatory disease because it thickens the cervical mucus, right? Right. When you're taking the first prescription, when you're giving the first prescription, it is important because oral contraceptive pills contain estrogen. It is not a contraception that you must take lightly. Always take a very good history, medical history, family history, drug history, and see whether any medications are there which are very conditions are there which are contraindicated for these women. So for that, to see what are the contraindications for oral contraceptive pills, you have to go through the medical eligibility criteria that I told and see what are the things that are contraindicated to give prescribed oral contraceptive pills, especially cardiovascular disease, migraine with aura, and any other risk factors like smoking, hypertension, obesity, previous thromboembolic events, thrombophilics, and dyslipidemias. These things are contraindications to start oral contraceptive pills, right? Right. If the blood pressure is high, even if it is controlled with any medications, you normally don't prescribe oral contraceptive pills. You try to go for a progesterone only contraceptive, right? These oral contraceptive pills have different doses of estrogen. Now there is 20, 30, and there's older days there was this 40 micrograms ethinyl estriol preparations as well. But more the estrogen, more the side effects. 20 is lower dose, but the problem is when it is low dose, it has its own drawbacks. Drawbacks like withdrawal bleedings, and if you miss for even 1 or 2 days, you will get pregnant. But when you have a higher dose, the advantage is the efficacy of the contraception component is high, but the side effect profile also becomes bad. So it's a balance between higher dose and lower dose estrogens, what is most suited for each and every woman. If you want a tighter control, a tighter control in the menstrual cycle, a higher dose estrogen would be better, but the side effect profile have to be explained to her before prescribing. Right. So this slide is a very crowded slide, but just to tell you about these categories of medical eligibility by different women. For oral contraceptive use. For example, now you see category 4 becomes any woman less than 6 weeks postpartum. We cannot give. That means category 4 is you cannot give this medicine. Any woman who's more than 35 years and smoking more than 15 cigarettes per day, you cannot give. Any woman with a blood pressure of more than 160 systolic and diastolic more than 95 cannot give. Any woman with aura and migraine, don't give. We cannot give. Any woman with a history of stroke, congenital heart disease, anticoagulants in the history or anything like that, don't give. Major surgery with prolonged immobilization, don't give. History of breast cancer, don't give. Any nephropathy, neuropathy or retinopathy or anything like that, don't give. What are the medical eligibility criteria? One, well, young women, right? Less than 40 years, more than 6 months, after more than 6 months, if they are breastfeeding during the postpartum period, it's safe to use. So if they have a normal body mass index, if they have only minor surgeries, no family history of breast cancer, and all these things, that is eligibility criteria number 1. So like that, when you take this book, it is in the internet free of charge. You can just refer that before starting a contraception to this women. With that, we can see that what are the contraindications to use oral contraceptive pills. Okay, so I'm not going to discuss these things much in detail because you can go into the book and listen. But basically, just see that there are medical eligibility criteria, category number 4. There are conditions for oral contraceptive pills. So you see, venous thromboembolism, when you are not taking combined oral contraceptive pills, the chances of VT events are about 5. When you are taking second generation contraceptive pills, it is 15. Third generation, which is higher, it is 25. But you see, pregnancy is very much higher than everything. It is 60 times you are higher of getting thromboembolic events when you are pregnant. That is because very high concentration of estrogen in the body during pregnancy. Right? It's nothing like risk like pregnant anyway. Okay, what to do about the missed pill? When you have a missed pill, it depends on the which 7 days that she missed it. We can divide the 7 days into 3 7 days, right? So normally, if she missed the pill just after the missed pills, that is pill-free period, that is first 7 days, then she is very high chance to get pregnant. So you have to take a emergency contraception pill soon, and also then you have to use a barrier method for the next 7 days. The best time to miss a pill would be the second 7 days. In the second 7 days, if you miss a pill, you just have to take use a barrier method for the next 7 days, and normally you will not get pregnant because anyway by the second 7 days the contraception, the estrogen and progesterone concentration has come to a certain plateau in your body. But then you go to the last 7 days. We take pills for 21 days, so there are 3 7 days. So the last 7 days, if you miss a pill, then what you have to do is you must not stop. You must not give a pill-free period. You just have to start the next pack straight away. That's the argument. So that is what you do when you miss a pill. Again, I will recap. I will tell you what you do when you miss a pill. So when you miss a pill, we ask what 7 days of your cycle did you miss the pill? Is it the first 7 days of the cycle, second 7 day, or the third 7 day? If in the second 7 day you are in big trouble, then of course what you have to do is you have to use a emergency contraception. Maybe you have to put a intrauterine contraceptive device or something like that, and then you have to use a barrier method for the next 7 days. Second 7 days is the safest to miss a pill because your concentration is now stable when you come to second 7 days, but still you have to use a barrier contraception for the next 7 days. Third 7 days, again, you are going to, if you give a pill-free period in the next 7 days, after the next 7 days, there's a high risk of getting pregnant. So when she miss a pill in the next 7 days, you have to start you have to continue with the pill pack, use a barrier method for the next 7 days. And when the pill finishes, you don't stay for a pill-free period. You start the next pack straight away. So that's what I have explained here. I will send this this thing to my demo. Then you can take this slide. Right? Other problem with oral contraceptive pills is breakthrough bleeding. It might be due to several reasons. One thing might be missed pills, sexually transmitted infections, pregnancy. Due to bad absorption of the medication, maybe vomiting, drug interactions, or diarrhea, or duration maybe of use may be too short. So early in the cycles of starting a oral contraceptive, you can have breakthrough bleeding. Breakthrough bleeding is a real troublesome thing. You have to give backup coagulation drugs like trinixamicum and mefenamic to control breakthrough bleeding. So it has drug interactions as well. Liver enzyme inducers like rifampicin, griseofulvin, anticonvulsants like phenytoin, carbamazepine, or topiramide, all these things, and antiretrovirals, and then St. John's wort, all these things can induce liver enzymes, cytochrome P450 liver enzyme system, and that will increase the breakdown of contraception pills, and that will cause validity of the contraceptive pills less. So when you are taking these medications, you must not give a pill-free period for 7 days. You might have to reduce the pill-free period more, or this when you are taking these medicines altogether, oral contraceptive pills must be avoided at all stages. Okay, this is not needed. Then you have progesterone only contraception. The next type of contraception is progesterone only contraception, which is widely used. So in Sri Lanka, we don't have the progesterone only pill, but it's a very important pill because it can be taken just after childbirth. It does not affect breastfeeding, right? So, but the only problem with progesterone only pill is that this pill you have to take on a daily basis, and you can't wait for 7 days pill free. You will definitely get pregnant because this progesterone stays in the body for a very short time, right? And you have to normally take it on the same day, same time. You must not even take hours apart. Then also the efficacy might be failing. It acts by reducing the sperm penetration in the cervix, and it reduces the endometrial receptivity for implantation, and also reduce the ovulation rate. So very successful one, but the window for error is very little. So it Seracet කියලා තිබුණා, එහෙම තියෙනවා. Denogest කියලා තියෙනවා. දැන් නම් ලංකාවට වැඩි එන්නේ නැහැ. It doesn't come because no agent bringing it, but those days we had that progesterone only pill, right? So you take a pill every day without a break, and the next pill is started soon as the last pack is finished. You don't give a pill-free period, right? And you try to take on, say, in the morning, as far away from the time of intercourse, so that it will be working at its best at the time of intercourse, right? If there's a missed pill, even if it is only 3 hours late, you have to understand that the efficacy is reduced, so you have to take additional pill and take additional contraception for the next 2 days, right? So these are these pills. When you are taking these progesterone only pills, you have to be very disciplined in taking it. Otherwise, you will get pregnant very soon. But luckily, you don't have it in Sri Lanka. So I'm not going to talk much about that. And then we go for non-oral contraceptions. The oral contraceptions were the ones that I talked now. Then you have the non-oral ones. The good thing about non-oral methods are that you don't rely, it doesn't rely on the patient for its compliance, right? So you don't have to adhere to a strict regime to drink medications when it is not oral, right? So it is long acting, and you don't have to worry about taking it every day. It will do its job while you can carry on with your life. So there are several types. You can have male condoms, female condoms, female dabs and caps, vaginal rings, contraceptive patches, injectables, implants, intrauterine devices, and intrauterine systems, right? So the typical use, you can see the condoms are the worst, right? Typical use is what like a normal person uses it. So the failure rate in Pearls index, it is 15 in male condoms. Female condoms 21. Diaphragm and cup 16. These are unacceptable as family planning methods. Best ones are implants. You see, it is 0.05. I'll tell you about implants a little bit later. So implants are the best, and you can see the difference. You see, implants. If you can see this implant, the perfect use and the typical use both have the same, because once you put this, it doesn't rely on the woman to use it. It will work by itself. So those are same. Even intrauterine devices, same almost, and uterine systems also same. So these are these are the best ones that you can use for a unreliable woman, or if a woman is having a busy schedule. These last three are the best to give. So this vaginal ring is called the Nuva ring. This Nuva ring also has the same estrogen and progesterone. You put it into the vagina. It's like a very thin and slender pessary, right? You put it in, you can take it out. When you're having sex, you can take it out for some hours, up to 3 hours, and then you can put it back when you go to sleep, right? And you have this patch. It is called the Evra patch. You see, this is the patch. This patch you can keep, is waterproof. You can keep paste it where someone cannot see, and it will work, releasing estrogen and progesterone. This is the Nuva ring. You can remove it while you want to have sex and then put it back. The advantage of this is that they can be used in a monthly basis. Once you apply the pessary or the patch, you don't have to worry about it for 1 month, right? So it fluctuates. The fluctuations, if you are not a reliable pill taker, these are better options if you really like to stay on the pill, right? But there are some side effects like vaginal irritation and skin irritation and so on, which you might have to tackle, right? So this is about the patch. The thing is, I'm not going to talk much about the patch and the ring because these are not available in Sri Lanka. Just to know that these patches are there. The ring is there, but it is not available. So if you go abroad, if you are going to England to reside, if you're going to be a doctor there, then you might be able to use these things. Same, these are the same as oral contraceptive pills, nothing different. Category 4 is because both are combined oral contraceptive. The pill, the patch, the ring, all these things are combined oral contraceptives. So the side effects, the category 4 criterion are the same. Then what about the injectables and implants? The implants, what we have is Jadel and Implanon. Jadel is for 5 years, Implanon is for 3 years, right? In Jadel, each contains levonorgestrel, and it's for 5 years. That is the commonest one we have in Sri Lanka. It has 2 rods. It is put into the underhand of the left arm, right? Commonest problem is irregular vaginal bleeding or prolonged menstruation or abnormal vaginal bleeding. Some complain of weight change and mood change and headaches and acne. Depends on the person. So if it is affecting in that way to that woman, you have to change that this thing. Sometimes implants can cause disturbance in mood or depression. If you have to always tell, if you feel down after using this, if you feel that you are different, always come and tell us soon. And they don't have any risk of venous thromboembolism. So they are very safe to be used in people who are contraindicated to take oral contraceptive pills. So this is Jadel device. You will get it in your finals for those keys. How to insert, how to counsel. Prabodh will talk about how to counsel them and how to put it. They might ask you the steps. So if you get irregular vaginal bleeding, still we have different methods of treating them. We can give tranexamic acid, we can give mefenamic acid, or we can give combined oral contraceptive pills about 3 or 4 cycles and control the bleeding. Then you have the injectable devices, injectables like Depo-Provera. It has about dose about 150 milligrams, and it is widely available. It is given every 3 months. Only thing is, return to fertility is might be delayed with injectable. So you don't give it to a primey or a woman who has not got pregnant, right? The advantage of subdermal implants like Jadel is, as soon as you remove it, the return to fertility is immediate. But for Depo-Provera, return to fertility might be prolonged, right? Because it is a long-acting progesterone, it will accumulate in the body. So the endometrium will become very thin and it will take a long time to grow back to normality again. So disadvantage is actually, again, every progesterone, the disadvantage they will have is menstrual disturbances, right? And mood changes and oily skin. These things can happen. Headaches, weight gain, acne, mood swings. These are classic progesterone side effects. Sometimes you can have weight gain because it might increase your appetite as well. But this weight gain property is not there for the subdermal implants because they give a very small dose of progesterone. But for DMPA, because there's a high dose, they might get appetite increase, and the return to fertility might be delayed up to 6 to 8 months. So that's a problem if you are trying for a pregnancy. So this is a Depo-Provera vial. You don't give Depo-Provera for very young women and very old women. That is because it can have effects in the bone density for these women, right? For young women, the bone is now it's in a highly growing stage. When you this Depo-Provera gives very high dose of progesterone, so it might induce a menopause-like state. When it's a menopause state, you all know menopause will cause reduction in bone density. So in a very young girl and a very older woman, we don't give Depo-Provera because it might affect their bone density formation. Then you have the intrauterine contraception devices. You have first is the copper and then is the Mirena IUD. The copper intrauterine device is very effective. It has copper in a shape of a T, the word T. Because of the foreign body and because of the spermicidal effect of copper, it acts in two different ways, right? Because it's a foreign body, it will prevent implantation and it will destroy the sperms as well due to copper. It doesn't affect weight gain and it doesn't cause any changes in mood or libido, and it can be used as an emergency contraception as well for 5 days. So it's a very, very important type of a contraception, right? But before putting that, you have to take a history. You have to do a clinical assessment. Only problem is it can, when you are putting it through the vagina, and if there's a germ in the vagina, you can introduce it to the uterus, and you can ultimately cause chlamydia infection in the tubes and all these things, and it can even stimulate subfertility. So depending on her sexual practices, you might have to see whether it suits this women, right? So its primary action is prevention of fertilization. Copper is toxic to the sperms and ova. It inhibits implantation due to foreign bodies, and also it has a long duration of action, so it can be kept up to 10 years in the uterus without any effects. So infection is the problem, but it is only there during the first week. And if there's it depends on the lifestyle of the woman as well. Other thing is penetration. If you insert it too deep, it can penetrate the myometrium, it can go into the abdominal cavity, and that is a big problem. Then you can have a peritonitis, right? It can be displaced with heavy bleeding, it can come down, and then you can get an unwanted pregnancy. And because of the risk of because of infection and all these things, the chances that there will be ectopic pregnancy, if you get pregnant, if it's a failure, and if it's a contraception failure and you get pregnant, and if the contraception was a IUCD, there's a chance of getting ectopic because there's a intrauterine device in the uterine cavity. So this is a copper T3, copper T380 IUCD that you use. This has to be inserted under strict sterile conditions. Then you have this more advanced system, the levonorgestrel intrauterine system. It is same as a copper T, but it has levonorgestrel progesterone, which releases 20 micrograms of levonorgestrel per day. It is licensed to be used for 5 years for contraceptive purposes, but for about 3 years if you are using for other purposes like reducing the menstrual blood loss and reducing endometriosis and so on, right? So any other, it is a medicinal device rather than a copper T. So it can be used for endometriosis, adenomyosis, fibroids, anything like that, as heavy menstrual bleeding, irregular vaginal bleeding, all these things will be reduced by levonorgestrel system. So it has its effect by releasing progesterone into the myometrium, and it will disrupt the sperm transfer and it will prevent fertilization, right? It will have a progesterogenic effect on the cervical mucus, which will prevent sperm penetration, and it will, because of that, the sperm penetration will be hindered because of the very thick this thing. They will not cause any problem with ovulation, right? It doesn't act by inhibiting ovulation. They will ovulate, but it doesn't get pregnant. So you insert it in the first 7 days of menstruation, right? So this is a picture of a Mirena coil. You can see this small part here. Here, the small part will have the progesterone, which releases little by little. So the side effects, the risk of insertion are the same as the copper IUD, like perforation, expulsion, and infection. But because there's progesterone, as I told you, the notorious side effects of progesterone is irregular vaginal bleeding. But 90% reduction in blood loss will be there after 1 year of using this type of contraception. So it actually drastically reduces the blood loss, menstrual blood loss, right? Some women will experience these progesterogenic side effects like mood changes, headaches, bloating, breast tenderness, and so on. So there are other methods like condoms, female condoms, diaphragms, spermicides. They are very unreliable, and they are not methods of contraception unless you are in emergency, right? Good. So don't be like this. First one was planned, other two is not planned. So as doctors, our duty is to help women to choose the best contraception. So they think that condoms are the easiest, condoms are best. You can see these are not methods of contraception. These are good for preventing other illnesses like AIDS and all these sexually transmitted diseases, but these are not for routine contraception, right? Then you have this emergency contraception, which will be discussed later when you come to final year. They are not routine contraceptions. These are not routine. And then go read about medical eligibility criteria. When you take about progesterone only contraceptions, they have very little category 3 and 4. They can be used for most of the women. But oral contraceptive pills, there are so many category 4 illnesses that you have to take the history before starting. Good. Right. So I think I discussed all the types of contraception that we have. Dr. Prabodhana will come back when he's free, and he will discuss how to counsel women to choose the best option of progesterone. Now you know the types. How to counsel about these methods will be discussed by Prabodhana, and the National Family Planning Program will be discussed by the Family Planning Association. Okay. Shall I leave then? I will send this presentation to the demo so you can get it, right?
Recording stopped.